Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Guys, I've been asked if I would break down the selection of a principal diagnoses. Think about when a patient comes in to the hospital and they've got 10 diagnoses and you're wondering, which one do I code first? Because you know reimbursement is based on your first listed diagnoses. So whichever diagnoses you specify as your principal diagnoses, that's where the weight of the reimbursement for your admission comes in at. So if I list the wrong diagnoses first, then I am interfering with the reimbursement rate for that visit. So as a coder, how do I determine which diagnoses is my principal or first listed diagnoses? So I wanted to make sure I take some time to clearly explain this to you. But first of all, I'm going to take you to the resource that I always refer you to when it comes to coding, and that is your coding guidelines. So let's look at these, and it's in section 2 of your coding guidelines. If you look here, I'm in section 2, and it says Section 2, selection of principal diagnoses. It's right there in your guidelines. It's section 2. We've been in section 1 in my previous video studying with you. So let's look at it. It says the circumstances of inpatient admission always governs the selection of the principal diagnoses. The principal diagnosis is defined in the Uniform Hospital Discharge Data Set, UHDDS, as that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. Okay? So again, it takes us right back to what I've always said to you, and that is whatever is the reason for bringing the patient in. Because remember, your patient's going to have comorbidities and complications. And let me break that down for you too, because I have to break everything down. I can remember when I was in school and the instructor talked above my head and I couldn't exactly follow. So let me try to break that. Complication is a condition that a patient may have that gets complicated. You could have diabetes. Diabetes might not cause you to have to go to the hospital, but if you go into some type of hypoglycemia or hyperglycemia and it causes complications, that's a complication. High blood pressure. Again, the diabetes and the high blood pressure are actually comorbidities. Comorbidities are conditions that patients have and they're being treated for on a daily basis, but it is not the reason for their admission. But by the way, they have to be treated for it while they're in the hospital. So we're still going to have to give them high blood pressure medication or treat their diabetes while they're in the hospital, but they could be in for something totally unrelated or doesn't have anything to do with it. So a complication is something that could go wrong with a condition, and a comorbidity is something that you live with daily, like hypertension and diabetes, but there is no effect of it that's causing you to be admitted at this particular time. All right, so if signs and symptoms, again, in a previous video I explained the difference between signs and symptoms, but if those signs and those symptoms lead to a definitive diagnosis, then those signs and symptoms aren't what you code the diagnoses. So how does this guideline break it down for you? Let's look at the first one. Codes for signs and symptoms and ill-defined conditions. Okay? And it says, A, codes for symptoms, signs, and ill-defined condition. Codes for symptoms, signs, and ill-defined conditions from Chapter 18 are not to be used as a principal diagnosis when a related definitive diagnosis has been established. Guys, if those signs and symptoms lead to a diagnosis, then don't code the signs and symptoms, just code the diagnoses. You've captured it there. What about B? When two or more interrelated conditions, each potentially meeting the definition of a principal diagnosis. If you ever read a chart and the patient actually has two conditions, and both of them, either one of them could actually be the principal diagnoses, how do you handle that? Well, in that case, either condition may be sequenced first. But ideally, you should go with the one condition, guys, that is the most resource intensive. Okay? What about C? When you have two or more diagnoses that equally meet the definition of principal diagnoses. In the unusual instance, when two or more diagnoses equally meet the criteria for principal diagnoses as determined by the circumstances of admission, diagnostic workup, and/or therapy provided, and the alphabetic index, tabular list, or other coding guidelines does not provide sequencing direction, any one of the diagnoses may be sequenced first. Let me give you an example. What if a patient is admitted with chest pain and shortness of breath? The admitting provider's definitive diagnosis lists congestive heart failure and pneumonia as the cause of the chest pain and the shortness of breath. But he gave you two diagnoses, congestive heart failure and pneumonia. So which one do I list first? It doesn't matter. Either one may be listed as the principal diagnoses because both are present on admission and they both equally are treated with IV meds. So both of them will be treated the same way. But review the medical record to determine if one condition requires more attention in terms of labor, resources, and/or management over the other. If one is more resource intensive, guys, that would be the one that you would go with. Okay, continuing. Let's look at D. D says two or more comparative or contrasting conditions. In those rare instances when two or more contrasting or comparative diagnoses are documented as either or, they are coded as if the diagnoses were confirmed and the diagnoses are sequenced according to the circumstances of the admission. And if no further determination can be made as to which diagnosis should be principal, then either diagnoses may be sequenced first. All right, what's a good example for that one? Let's say, if both conditions are coded, either one can be presented as principal. It doesn't matter because usually in a case like this, they'll carry the same weight as far as reimbursement. They're usually in the same body system. So it really doesn't matter. They're going to be treated the same way. So it's going to carry the same amount of weight. E has been deleted. And then F, original treatment plan not carried out. And we've seen cases like that, guys. It says the original treatment plan not carried out sequence as the principal diagnoses the condition which after study occasioned the admission to the hospital, even though the treatment may not have been carried out due to unforeseen circumstances. So if they were admitted for a particular diagnosis, that diagnosis remains the diagnosis. For example, fibroid tumors. Patient comes in to have elective hysterectomy to remove the uterus in hopes of, getting rid of the fibroid tumors. Well, when they get there to do the elective hysterectomy and the equipment for some reason doesn't work, then the principal diagnosis still remains the same. The patient came in for an elective hysterectomy for fibroid tumors. So fibroid tumors is still the principal diagnosis. What about complications of surgery and other medical care? We've seen that happen. When the admission is for treatment of a complication resulting from surgery or other medical care, the complication code is sequenced as the principal diagnoses if the complication is classified to T80 through T88 series and the code lacks the necessary specificity in describing the complication. An additional code for the specific complication should be assigned. So if they came in for a complication resulting from surgery, identify what it is, but identify it first as a complication and then identify what complication occurred. So in this case, you need two diagnoses, but your first listed is the actual complication code. Okay? And then H is for uncertain diagnoses. if the diagnosis document at the time of discharge is qualified as probable, suspected, likely, questionable, possible, or still to be ruled out, or any other similar terms indicating uncertainty, then code the condition as if it existed or was established. The basis for these guidelines are the diagnostic workup arrangements for further workup or observation, an initial therapeutic approach that corresponds most closely with the established diagnoses. Okay? So when you have uncertain diagnoses, as long as the physician treats the patient for what was suspected, likely, questionable, probable, possible, or still to be ruled out, then you can still use that diagnosis because that's what the physician is treating. Okay, guys? I hope this begins to make a little more sense as you begin your studies of these guidelines, because, guys, what I'm finding is that you're panicking. Stop panicking and just think about the situation and what's going on. Apply these rules right here in section 2. Just think about what's going on with your patient when they're coming in. Whatever is bringing them in, if it's a sign or a symptom, and if it leads to a definitive diagnosis, you've got your diagnoses. If it's already a confirmed diagnosis, you've got your diagnoses. They might have some complications or comorbidities that you, in addition, have to code, but you've got it. It identified what's wrong with your patient. Which one should be your first listed diagnoses? That which brought the patient in. They could have hypertension. They could have diabetes. They could have sarcoidosis. They could have all these other conditions wrong with them. But what brought them in? What made them come in for care, for treatment? That's your principal diagnoses and your first listed diagnoses. Now again, when I think of principal, I think of inpatient stay. When you're on an outpatient basis, you can go to your doctor for a sore throat, a headache, or any of these other signs or symptoms. But on an inpatient basis, those signs or symptoms, when they lead to a definitive, they define for you exactly what's wrong with your patient, then that definitive diagnosis becomes your principal diagnosis, and that's your first listed diagnoses. The rest, 2, 3, 4, 5, 6, 7, however many more diagnoses, I've been taught you put your heavier conditions after your principal if they have diabetes or hypertension or any other condition that requires, say, for example, daily medications. Code those. Oh, by the way, I'm anemic. I'm not taking any medicine, but I've got anemia. Well, that would be an additional diagnosis that I could list if my hemoglobin, hematocrit, or my lab values show it. But some other diagnoses that they tend to have in the history, oh, they had a cholecystectomy 20 years ago. Guys, if it doesn't have a bearing on today's admission, some of this stuff you don't have to code. Only if it has a bearing on today's admission would I also include those additional codes or diagnoses that we're going to list with these conditions, guys, with these diagnoses. All right, hope I bring a little more understanding to those of you that were questioning me, how do you know which first listed diagnoses on an inpatient chart should be, or how do you sequence your codes? Your principal diagnosis, again, is that which after study was found to have occasioned or caused your patient to come in for care. All right, guys, thanks. I'll see you in the next one.